Ike, a consultant obstetrician and gynecologist of the Premier Specialist Medical, Victoria Island, Lagos. We'll be discussing hypertensive disorders of pregnancy, and we'll come down to management of eclampsia. The learning objective is we are going to define and classify hypertensive disorders of pregnancy and differentiate between each class. Students should be able to diagnose and treat women with hypertensive disorders, and also to identify the women at risk, most importantly, and to know how and when to deliver them. It's also important to know how to formulate their follow-up plan. Be able to define hypertension in pregnancy and classify hypertension in pregnancy, then diagnose hypertension in pregnancy and also treat these women and how to follow them at the end of the lecture. These are the expectations. Preeclampsia, eclampsia, and HELLP syndrome affect women and lead to a very high percentage of maternal and perinatal complications. Some women develop preeclampsia without showing any classic symptoms. This is actually very serious. And because of this, there is a statement that the proteinuria is no longer recommended, or rather must not necessarily be present for a diagnosis of preeclampsia to be made. Worldwide, each year, preeclampsia is responsible for over 70,000 maternal deaths. And women from Caribbeans actually record up to 26% of deaths. Of course, in Africa and Asia, up to 9% among mothers. This is a very recent classification or statement made by ACOG. And 16% of the maternal mortality may be due to hypertensive disorders. This is quite high when you even look at even the high-income countries. The complications of pregnancy that which preeclampsia can cause can be up to 2 to 8%. And worldwide, for preterm delivery, they contribute up to 15% of deaths. The incidence of preeclampsia is increasing world over, and this is a bit disturbing because when you look at the maternal age is increasing, obesity is on the rise, especially in American and other elite cities. The use of artificial reproductive technology and medical commodities are on the rise. But however, it is clear that for Afro-Caribbean women and people with multi-fetal gestation, that preeclampsia is quite commoner, even in the primary gravidae. It is also clear that children born with preeclampsia or by the eclamptic mothers are more likely to suffer from metabolic syndrome and cardiovascular diseases and hypertension at earlier ages. The pathogenesis of preeclampsia and eclampsia is actually not clear, but however, genetic and other dietary deficiencies have been implicated, even coagulation problems. But most across boards is the issue of the abnormal trophoblastic invasion, which around 16 to 18 weeks, that there will be, once there's a problem with the trophoblastic invasion at this period, that such women are liable to develop preeclampsia when monitored along the line. And this is very pertinent. However, because it's still theories, so most of the time, theories 1 or theory 2 might conflict what theory 1 has said, but this has always been what is being recognized. Classifications of hypertension, so many classifications has been noted. However, the one that is endorsed by American College of Cardiology and the American Heart Association has classified hypertension to be either class 1, 2, 3, or 4, where class 4 is staged as stage 2 hypertension, where systolic is more than or equal to 140 millimeters of mercury and diastolic is greater or equal to 90 millimeters of mercury. But what you will note in this classification is that, like for instance, class 2, where it is noted that increase in systolic of blood pressure of 120 to 129 and diastolic of more than 80. If this classification is used, most of the time, that means a lot of cohorts will actually be termed that they have hypertensive disorder. However, the International Society of Study of Hypertension in Pregnancy, the recent classification in 2018, has tried to make this a little bit clearer. And this was the work which was published by Mark A. Brown et al. They tried to say that hypertension known before pregnancy or present in the first 20 weeks, or hypertension arising de novo at or after 20 weeks. So if we are going to classify just, it said hypertension known before pregnancy or present at the first 20 weeks, that's the first class, or hypertension arising de novo at or after 20 weeks. So we are going to now talk about classification based on these two subheadings. So for ease and to make the lecture clearer, we'll just class this class A and the other class B. So for class A, we say hypertension known before pregnancy or present in the first 20 weeks. Now, there is further subclassification of this class A, which is class 1, 2, and 3. For class 1A, it is chronic hypertension, which is subclassified further into essential and secondary. Usually essential, most of the time, the cause is unknown, but for secondary causes, largely due to kidney diseases. Then class A2 is white coat hypertension. We're going to see this in details, while class 3 is mixed hypertension, a little bit new terminology, which we are going to see as we advance in the lecture. Then class B is hypertension arising de novo at or after 20 weeks gestation. Subclassification of this is B1, which is transient gestational hypertension, B2 gestational hypertension, B3 is pre-eclampsia. Now, the pre-eclampsia, if you notice there's an asterisk there, we are talking about the de novo or superimposed or chronic hypertension. Now, pre-eclampsia de novo can be a classification on its own. However, for such women, there can be pre-eclampsia. However, there can be a superimposition on a woman that already has chronic hypertension. So it's important for us to know that this particular state can occur. Now, very importantly is the term severe pre-eclampsia. In the past, this is a terminology that is being used. But this has been discouraged in clinical practice because some women that are pre-eclamptic, if you classify them as mild, and you now make the management to be a little bit relaxed, that is not recommended because a mild pre-eclampsia can immediately, within a trickle of hours or just within a few weeks, translate into a severe pre-eclampsia. So it is now recommended unless one is talking about a situation whereby one is dealing with research. Then you can go ahead and say, okay, there is mild pre-eclampsia or severe pre-eclampsia. However, for clinical practice, it is recommended that pre-eclampsia, when we now be classified as pre-eclampsia with severe features. That's a better terminology. With severe features or without severe features. We are going to see details of this as we go ahead with this lecture. Let us define some basics. What is hypertension? We define as systolic blood pressure greater than or equal to 140 and or diastolic blood pressure greater than or equal to 90 millimeters of mercury. Usually it's said that this should be measured within 15 minutes. Now, for within 15 minutes is said, especially when it's severe. However, for the less severe form, remember we said that there's a modification of the use of severe right now. So for ordinary blood pressure that is just 140, 90, you can actually reduce this, repeat this within 4 to 6 hours. But the recommendation right now is that once there is blood pressure with severe features, this should be confirmed within 15 minutes. And that is very important. And it is also recommended that this repetition is actually to confirm whether the hypertension is actually sustained, because one can actually get a raised blood pressure. By the time the blood pressure is repeated, it will no longer be in the range of greater than or equal to 140. That does not suffice as hypertension. It's also important to specify the type of sphygmomanometer that will be used for this measurement. The liquid crystal sphygmomanometer is the tool of choice for the management. However, if this is unavailable, it's important to use the validated or appropriate calibrated automated device. So usually we talk about the liquid crystal, okay? That's the one we call digital. However, when this is not available, you can go ahead and use calibrated. This is the recommendation of International Society of Study of Hypertension in Pregnancy 2018, which we have talked about in terms of classification. Now, the gold standard for measurement remains the mercury sphygmomanometer. One is not disputing this. That still remains the gold standard. When all has failed, it must be the mercury sphygmomanometer must be used for this measurement. It is known that in literature, one is the use of the clinical use of the mercury sphygmomanometer is being withdrawn for certain reasons. because of mercury injury to the subject. However, we cannot forget to say or mention that this is still the gold standard. Aneroid devices, of course, will require a lot of calibrations because most of the time there are error or parallax and so on. So it's important to calibrate all this and ensure that it follows a particular standard protocol. If an automated device is used, it should have been validated for use in that pregnancy. So there must be a standard protocol for which that particular device is being used. Now, for the measurement of blood pressure, it's important to note that this pregnant woman must be at rest. It is not a woman that just finished exercising, you want to measure blood pressure, that will be erroneous. So she must be at rest, and the arm has to be held at the level of the heart. So these are some of the standard protocols that must be observed. Then if the woman is supine, she should be on the left lateral position while the measurement is being taken. It is important to also use the appropriate side cuff, because higher cuffs can actually increase the readings, and this must be used. So for women with higher cuffs, appropriate size cuffs should be used, and the arm circumference greater than 41 centimeters is important to use higher cuffs. For the correct cuff sound, what is recommended is still the fifth, because most of the time, once an error is made on the muffling, one must recognize that it is when the sound disappears, not on the fourth. And this is appropriate to ensure that the right blood pressure is measured. Now, let us look at significant proteinuria. Remember, we said in the beginning of this lecture that the presence or absence of proteinuria must not necessarily be key for the diagnosis of preeclampsia. However, we must be able to ensure that there is either proteinuria or not proteinuria. It is important, and we'll see why it is still important for us to ensure that there is significant proteinuria. This significant proteinuria has definition. It can either be qualitative or quantitative. For the qualitative, we are looking at the issue of measuring it based on dipstick, and for the quantitative, we are looking at the 24-hour profiling or the use of spot urine to measure the significant to measure protein in urine. Now, when we look at the 24 hours measurement of proteinuria, this remains the standard of estimation of protein in urine. So proteinuria will be defined as total protein collection that is greater than 300 milligrams per day in a 24-hour collection. Please note that this 24-hour collection is actually time challenging, because for you to start collecting over the 24-hour period and when you actually needed to make a quick assessment of this patient, this might be a challenge. However, there is another protocol that can be adopted for this patient, especially when immediate diagnosis is needed. That is the spot protein creatinine ratio. This can be put on the spot immediately and using a single urine sample. Once the level that is greater than or equal to 30 milligrams per millimole of this spot urine protein creatinine ratio is gotten, this is regarded as what? As significant proteinuria. So we must note the two of the 24 hours and also the spot urine for the diagnosis of significant proteinuria. However, let us quickly say that a negative test has a high negative predictive value. So what it means is that if once one measures protein and there is no protein in the urine, that one can say that you can actually say that this patient does not have protein at all. But when there is a positive test, this must be followed up with 24-hour urine collection. That is to tell you that even though that a patient can benefit from spot urine, but once this is significant, it is important to follow it up with what? 24-hour urine protein collection, because we said that this is actually the gold standard to say that this patient has significant proteinuria. However, for a patient that we have, particularly a patient that have nephrotic rate of more than 230 milligrams per millimoles, it is important for us to know that this patient must have 24 hours. That is, remember we said greater than 30 milligrams per millimoles. So by the time one is getting more than 230, This is defined as nephrotic range, and such a patient must have a 24-hour urine documented in the patient case note. For the qualitative analysis we talked about the issue of use of automated dipstick. This is actually what is recommended, but most of the time is not available in our environment, but it can be in most high-profile climbs. Once there is more than or equal to 1+, which is equivalent to 30 milligrams per DL, a spot urine creatinine ratio should be performed. Now, this is a rider. One can, remember we said if it's available. If you measure the automated dipstick and there is 1+ or more, which is equivalent to 30 milligrams, kindly perform a spot urine for that particular patient. And once you do the spot urine and it is greater than 30, you should also follow up with a 24-hour urine protein collection. However, a negative dipstick then does not need any further the spot urine testing, because if it's negative, that means that it is unlikely that will still be protein, in the urine. This is the new recommendation as against what was being taught earlier. Proteinuria is not required for diagnosis of preeclampsia. We have said it earlier, and we are putting it in capitals again. The degree of proteinuria provides little additional risk, except in nephrotic syndrome. So it is important to know that before, proteinuria is really central, but one is trying to really say a little bit about it. It is not, so the degree of proteinuria does not provide just little additional risk, except if that particular proteinuria is in nephrotic range. We must make that addendum. There are no markers of severity, the degree of proteinuria is not really a marker of severity of preeclampsia. This is a little bit different from what we know before, but this is the new recommendation, and that is what we're using to. So, massive proteinuria, is the definition is still the same, greater than 5 grams in 24-hour urine of protein. However, if it is massive, just note that this is associated with severe neonatal outcome and earlier delivery when proteinuria is massive. Let me take that again, it's a little bit. So we say degree of proteinuria provides little additional risk, except in nephrotic range. Now, when proteinuria is massive, this has been shown to have severe neonatal outcome for those patients with massive proteinuria, and they tend to deliver earlier than when compared to the other cohorts. The decision to deliver is, however, not based upon the degree of proteinuria. These are classic statements, and we should be able to know them during this lecture. Now, let us look at class A. Hypertension known before pregnancy or present at the first 20. Remember I said that the Society of Hypertension in Pregnancy, I tried to make this a little bit simple. Class A and Class B and other subclasses. So, how do we define gestational proteinuria? You said this is the new onset of proteinuria in pregnancy without other features of preeclampsia or primary renal disease. New onset of proteinuria in pregnancy without other obvious features of preeclampsia or primary renal disease. This is in 2018. And the blood levels of placental growth factors for those that have the facility to measure this are intermediate between those of normal pregnancies and those that have preeclampsia, and this may be suggesting that these women might have early form of preeclampsia. Monitor these women very closely, very importantly, for the remainder of their pregnancy, as well as to assess proteinuria at 3 months postpartum. So it's not enough for the patient to deliver and go home. Please ensure to call this patient back in the next 3 months and remeasure the proteinuria, the protein level in the urine, to ensure that this patient is not still having massive proteinuria or surpassing protein in urine. That is very significant. For the chronic hypertensive, it's important to know that this is a high blood pressure predating the pregnancy or recognized at less than 20 weeks gestation, often diagnosed during the first or early second trimester. Remember that we said less that the marker for what differentiates the gestational from the chronic is that there is 20 weeks. One is less than 20 weeks, one is 20 weeks and beyond. So it is important to note that so most of the time it is when these women come, especially, but in sub-Saharan Africa where women don't book early, most of the time this might be missed. And when they are missed, it becomes an unclassified phenomenon. So you don't necessarily know whether this patient is actually having this the hypertension before pregnancy or after 20 weeks. However, the marker is the 20 weeks. Often diagnosed during the first or early second trimester. Ideally, this office or clinic hypertension should be confirmed by a 24-hour ambulatory blood pressure and BP monitoring, or after repeated measurement over hours at the same visit, or on 2 consecutive antenatal visits. So it is not enough to just have a one-off measurement in the office or during the clinic. No, that this patient should have this blood pressure monitored over at least 24 hours, or over hours at the same visit, or 2 consecutive antenatal visits. This is very, very important, because remember that when we are trying to define hypertension initially, we said that one-off measurement of hypertension is not enough. That is always good to have at least 2, and if it's sustained, that one can go ahead and say that this patient is hypertensive. There's also another group we call the white coat hypertension. Is, however, still a possibility for this chronic hypertensive. Once you put it in parentheses, we are still going to consider what white coat hypertension is all about. Then for chronic hypertension, it's mostly due to essentials, with few of them being secondary. Remember, we said initially that the essential one might not know what is actually causing it, but for the secondary hypertensions, most of them might be due to renal issues. All women should have their home blood pressure devices checked against a calibrated sphygmomanometer automated device, validated for use in pregnancy and pre-eclampsia, before using this device at all. So it's not enough to just go and pick up a sphygmomanometer and start using. This must be calibrated against a particular standard measuring device before being used, so that one can actually say this is either high or low. In the absence of severe hypertension, which has been defined as greater than or equal to 160 millimeters of mercury and or diastolic of greater than or equal to 110 millimeters of mercury, average blood pressure over several days is better rather than actual upon single readings of home blood pressure. Again, we are still talking about the issue of measuring blood pressure over the time, over days, if possible over 2 visits, before one can actually make that assertion. Now, for white coat hypertension, usually for one reason or the other, patient can come into the office or into the clinic and we discover that the blood pressure is increased. But this patient has never at all, while at home, has blood pressure increased. And there is criteria. So we said elevated office or clinic blood pressure is greater than or equal to 140 over 90 millimeters of mercury, but normal blood pressure measured at home or work, which is divided as less than 130 over 85. So when this occurs, one should note, because most of the time it's the patient that will tell you that, doctor, this blood pressure has been normal at home, that each time I enter here, it goes up. So you should, at that point, start thinking possibly this patient might have a white coat hypertension. It is not entirely benign condition and can convey an increased risk of preeclampsia. This is a recommendation by the current ISSHP 2018, that even if you notice it, don't relax, that if such a patient might have an increased risk for preeclampsia. Up to 1 to 4 patients with elevated clinic, that is white coat hypertension, elevated clinic or office BP have white coat, up to 1 to 4. So it's quite common. So once you see that, you can actually entertain that such a patient might actually have this white coat hypertension. The class B, hypertension arising de novo at or after 20 weeks of pregnancy. De novo or at or after 20 weeks of pregnancy. Now, the first among these is the transient gestational hypertension. This is a little bit new definition in ISSP 2018. And what is it all about? It said this is de novo hypertension that develops at any gestation but resolves within treatment during the pregnancy. So remember that it is a subclassification of de novo. Okay? So now it developed during the pregnancy but resolved without treatment. So this patient did not receive no drug, nothing. No diet modification, but actually resolved without treatment during the pregnancy. So the emphasis there is without treatment. So it is not a benign disorder, one must know that. It's associated with about 20% chance of developing preeclampsia. and also 20% chance of developing gestational hypertension. Like we said, it is not benign in itself. They monitor such patients very closely with calibrated home blood pressure measurements, and you should encourage the patient to come to the hospital with a diary that will stipulate how their blood pressure is being measured. For gestational hypertension, this is a common one, we are aware of this. This gestational hypertension is hypertension arising de novo after 20-week gestation in the absence of proteinuria and without biochemical or hematological abnormalities. Now, the marker there is absence of proteinuria and without biochemical or hematological abnormalities. This is very, very important. And once this before in the past, we used to call it pregnancy-induced hypertension. But the new terminology is gestational hypertension. Okay, about 25% of early onset gestational hypertension, that is less than 34 weeks, some definition will say less than 35, but what is common is less than 34 weeks, that's the early onset, will progress to preeclampsia, and these will have poorer outcomes. So this is important for us to know that it's not uniformly benign, like we said earlier, and the risk of complication is dependent on gestational age at which it develops. Remember, we mentioned the early onset. Okay, and there is no test that can reliably predict which women will develop this gestational hypertension at a later date. However, we are going to mention over the course of this lecture that there are some other tests that have been recommended that can be done for this patient, and one can use it to say, okay, so patient can actually have gestational hypertension or preeclampsia in future. Gestational hypertension is associated with cardiovascular disease in the long run, so one must know that and tell the patient during counseling. Let's look at preeclampsia. Preeclampsia is a complex medical disorder that involves the presence of de novo hypertension after 20 weeks gestation, accompanied by proteinuria and or evidence of maternal acute kidney injury, liver dysfunction, neurological features, hemolysis, or thrombocytopenia and or fetal growth restriction. Yes, I must say this is quite a gamut of a lot of terminologies mentioned, but however, it's important to know that preeclampsia is complex. That was how we started the definition, and we can look at the gestational age at which it started after 20 weeks, and the accompanied by proteinuria. But remember what we said, that proteinuria currently is no longer mandatory for the diagnosis of preeclampsia. Therefore, a patient can actually have all these features, but there is no proteinuria. But so far, one is able to diagnose that this patient has fetal growth restriction with other features. Please go ahead and diagnose that this patient has preeclampsia. Classifying preeclampsia as mild, we have said this earlier, and severe has been discouraged. Nobody uses this anymore. So it's better to just say that preeclampsia with severe features or preeclampsia without severe features. And preeclampsia, of course, we said earlier, can rapidly deteriorate without giving any warning sign at all. Commonest, okay, now let's look at the clinical presentation of preeclampsia. Most of the time, one can pick this when a patient comes maybe during a clinic, and one measures the blood pressure and we discover that it is a high, and then most of the time proteinuria might be there. Then this can trigger off some investigation and further investigations. However, we should know that symptoms may present late, and that is really not a very good form. If it presents late, and sometimes you might have mild forms, but by the time a patient starts having these features, such a patient will be classified that he has preeclampsia with severe features. The features are epigastric pain, nausea, vomiting, peripheral facial edema, headache with or without visual scotomas, blurring of vision, or a patient that has severe hypertension, which we have earlier defined, are greater or equal to 160 all over, greater or equal to 110 millimeters of mercury diastolic. For the examination of this patient, it's important to note that if a patient may have hyperreflexia with marked clonus, again, that is still in keeping that this patient has preeclampsia. It may show altered mental status. By the time a patient is start having all this, right quadrant tenderness, please note that these are all the signs that are confirming the severe feature that we earlier mentioned. And like we said, they are markers of severe disease and can be rapidly evolving symptoms should raise concern about impending severe disease. So a patient, remember we said the issue of mild and severe again does not come into place, because a patient with just maybe is not seen very well, before you know it, such a patient is having headache, before you know it, and that, I mean, it can even go to eclampsia. So please, such a patient must have care. Okay, preeclampsia is gestational hypertension accompanied by one or more of the following new onset condition at or after 20 weeks. We've mentioned, we were just trying to summarize. We said proteinuria earlier, which is not. Then other maternal organ dysfunction must be noted. Acute kidney injury, which we define as creatinine greater than or equal to 90 micromoles per liter. Liver injuries, once there is parenchymal affectation, one should know that there is a severe features of creatinine. Then maternal organ dysfunctions, once the hematological complications as listed, platelet count less than 150,000, and the uteroplacental dysfunction, which can manifest as fetal growth restriction. These are all the features that one should see, that one can make an assessment that the patient has preeclampsia, and not what it used to be definition just about proteinuria alone. What are the risk factors of developing preeclampsia? Once one picks this, especially during booking, one should know that this might be a patient that may develop preeclampsia in the future. Prior preeclampsia, that is a giveaway. Such a patient must monitor very closely. Chronic hypertension, assisted reproductive techniques. Now, are there tools for predicting those at risk? We said really that these tools are not absolute, but they can help. And primary among them is the uterine artery Doppler studies. For patients, this can be done around the mid-pregnancy period, around 20-22 weeks. And once you're looking at the resistivity index and so on, once this is done, once we say that this patient may be at risk of developing preeclampsia. There are other measurements of angiogenic factors, the endoglins, the presence of them, the pregnancy-associated plasma protein A, okay, and the homocysteines, the presence in the bloodstream. The uric acid is also central. Once we look at the level, once it is raised, one can say that this patient is at risk of developing risk of preeclampsia. We've mentioned the Dopplers, we said earlier, 20-22 weeks. And the NICE recommends that using maternal age, history, body mass index, and number of fetuses to select women for treatment with aspirin. These are some of the recommendations about preeclampsia, especially when we said those at risk, that we can use all these parameters to know those that will benefit from aspirin. About 50% of all women will be screened positive following NICE model. Sensitivity is about 77%. And routine antenatal care with regular blood pressure monitoring throughout later pregnancy has a central role. So it's important that once we make the diagnosis, that this patient will continue. What are the predictors of preeclampsia? We have mentioned all this earlier. And but there are the less strong associations of factors at risk. Primary parity is one of them. If a patient is a primary gravida, well, that is has been said is a long, strongly associated risk factor for development of preeclampsia. Advanced maternal age has also been notified, and also the short duration of sexual relationship less than 6 months prior to the pregnancy and primary paternity, or both change in paternity and interpregnant interval of more than 5 years. Factors less strongly associated with preeclampsia: chronic kidney disease, connective tissue, and factor 5 Leiden. Now, let's look at monitoring in preeclampsia. Very importantly, because we know that, remember the definition, we talked about the issue of the fetal growth restriction. So it's important that the fetus should be monitored as well as the mother. So confirming fetal well-being is central, and also to be able to rule out the presence of fetal growth restriction is also very, very important. Because remember that there are other parameters to make the assessment of preeclampsia. So that does not necessarily mean that there must be fetal growth restriction at the outset. So once it's not there, that must be looked out for, and such a patient will monitor very closely. Blood pressure monitoring, of course, that one is central to ensure that it does not escalate. Repeat assessment for proteinuria if it's not already being done. Such for principles of management, it's important that such a patient should be admitted. This is a recommendation by International Society for Study of Hypertension and Pregnancy and the Pre-Eclampsia Community Guideline. It said, admit all women at the use of preeclampsia to complete a full maternal and fetal assessment. That's very important. Then stabilize the blood pressure. Finalize a plan of care prior to considering outpatient follow-up for some people that benefit from it and other management. Ultrasound assessment is sent. We talked about the issue of Doppler studies. That should be done of the umbilical artery. Then perform a full blood count, looking at the blood levels and other parameters of the full blood count, the coagulation profile, the international normalized ratio, prothrombin time, and the protein time of coagulation. All these things should be assessed. Renal and liver function tests. You remember that there is a possibility of parenchymal affectation of the liver enzymes. Uric acid is important. We mentioned that earlier, and may be benefiting in confirming the diagnosis, but it is not related to maternal or fetal outcome. Remember what we said about the severe proteinuria in the other slide, but we are saying right now that uric acid being increased is not related to maternal or fetal outcome. A normal result, however, of uric acid does not rule out preeclampsia. So this statement should be understood very clearly. Okay, for the blood pressure is persistently elevated, more than 150/100, consider commencing antihypertensive therapy. This is very, very important. A patient that is coming to you in the clinic and is persistently elevated blood pressure 150, please consider antihypertensive therapy, which is the. Then during admission, check blood pressure at least 4 hourly, and a 24-hour urine collection. We said that the gold standard for quantification must be done and should be performed. Treatment can be commenced based on dipstick. Remember what we said about dipstick? It's either automated. When automated is not available, please use the qualitative one that is the normal dipstick that we use in most hospitals. And remember again, we talked about the issue of the challenge of 24-hour urine protein collection as regards the timing. So spot urine can be done. And of course, all the things we said is like we're just trying to summarize everything now. Consider outpatient if blood pressure is stabilized, laboratory studies are normal, no concern about fetal well-being, and patients have good understanding of their condition. This is very important. In fact, the last statement is so key because if the patient does not understand that hypertensive disorder in pregnancy is a continuum and can move from gestational hypertension to eclampsia, so the patient should not allow to go home. Okay, the ACOG recommendation, treatment only blood pressure over 160, 110. But unlike what is advocated in modern, so AIG is saying that greater than or equal to 150, 100, we should stick to that. WHO awaits further studies that World Health Organization to clarify the issue in near future concerning these two different values that were quoted by ACOG and the International Society of Hypertension in Pregnancy, hypertension in pregnancy. In all cases, avoid reducing the blood pressure below lower limits of 110/80. This is so key because this can actually lead to the risk of placenta underperfusion and lead to fetal death. So, in as much as one is trying to reduce or control the blood or stabilize the blood pressure, it shouldn't be reduced less than 110/80. This is very, very key. Now, what are the scenarios that one can consider delivery? Deliver the fetus if the following: at 37-week gestation, that is term, and 0 day, please deliver the fetus. There is nothing you are waiting for. Okay, then remember that delivering of the placenta is still remains central as in parentheses curative for preeclampsia, eclampsia in pregnancy. Repeated episodes of severe hypertension despite maintenance treatment with 3 classes of antihypertensive we mentioned. So if the patient is on labetalol, the patient is on nifedipine, the patient is on alpha-methyldopa, the patient blood pressure is 6, please deliver that patient. Progressive thrombocytopenia, please deliver. Progressive abnormal renal or liver enzymes, please deliver. Pulmonary edema, go ahead and deliver. Abnormal neurological features, for example, severe intractable headache, repeated visual scotomas and convulsions, their patients should be delivered. Remember, you must stabilize and go ahead and deliver. Non-reactionary fetal status, patients should deliver, especially when the fetus is above the age of viability and the at least more than 50% chance of survival if delivered. Mode of delivery for hypertensive disorders are not absolute indication for cesarean section. This must be stated very clearly. Trials have shown that women with gestational hypertension and mild preeclampsia at time, remember mild in parentheses, we don't use the term anymore, who have variable cervix may benefit from induction of labor compared to others. This is now because of the issue of, but remember that time, as you are doing induction, you can monitor the woman very closely. Consider cesarean section if pregnancy with severe features is remote from term with clinical evidence of fetal compromise. Studies have quoted successful induction in even women with 28 to 34 weeks. Then 32 to 34 weeks is actually higher, about 86.8% of cases. Post-delivery, please don't forget. Early postpartum period, for at least 3 days postpartum, preeclampsia are at high risk for preeclamptic complications. So it is not yet Uhuru. The patient had delivered, that does not mean they're not going to have complications. So such patients should be monitored very closely, monitor the blood pressure, clinical condition, at least 4 hourly while awake. Antihypertensives administered antenatally should be continued. Treat any hypertension before day 6 postpartum. Withdraw antihypertensive therapy slowly over days, but not cease abruptly. This is very important. It has to be tapered down gradually while the blood pressure is being monitored. Eclampsia syndrome may develop for the first time in early postpartum period. So note this, not because patient had delivered, patient can actually have what we call a typical eclampsia, and that must be noted. Avoid non-steroidal anti-inflammatory agents like diclofenac for postpartum analgesia in women with preeclampsia or no renal disease, unless other analgesias are not working. This is a recommendation by the current International Society of Study of Hypertension in Pregnancy. All women should be reviewed at 3 months. We said it earlier, postpartum, to ensure that at least blood pressure, urinalysis have normalized. This is actually the time you can say you have treated this patient. And please note that this is not a patient that you go ahead and say, okay, go home. You actually refer them to the cardiologist to continue their management even though their blood pressure remains normal. Refer if proteinuria or hypertension persists. Achieve pre-pregnancy weight over 12 months to limit inter-pregnancy weight gain through healthy lifestyle. That's very, very important. Remember that obesity, we mentioned, is one of the high risk for developing preeclampsia. Annual medical review should be lifelong. That's very important. Remember what we said, you refer to the cardiologist to continue when the obstetrician and gynecologists are done. Further recommendation, preeclampsia, transient gestational hypertension and gestational hypertension are characterized by new onset hypertension. We've mentioned this. Normal blood pressure is documented with pre-pregnancy or early pregnancy, before pregnancy-related decrease in blood pressure. For the transient gestational hypertension, we make few statements. We usually say arise in 2nd or 3rd trimester, and the hypertension is usually detected in the clinic, but settles with repeated blood pressure readings, okay, such as those taken over the course of several hours in a day assessment unit. So this is a bit different from white coat hypertension we mentioned earlier on, but must be present from early pregnancy. About 40% risk of developing true gestational hypertension. So, and preeclampsia in the remaining part of the pregnancy. Now, the terminology marks hypertension. Remember we mentioned earlier, this is characterized by normal blood pressure at the clinic or office visit, but elevated at other times. So, ambulatory blood pressure monitoring devices are very important in this case because sometimes I see the patient is not saying the whole truth, but that is actually what is happening. And or automated home blood pressure monitoring at home. So consider this diagnosis when patient has unexplained abnormalities consistent with target organ damage from hypertension, but there is actually no apparent hypertension. Remember that we said that mild hypertension is a form of chronic hypertension. We have mentioned the concept of using mild and severe preeclampsia, which has now what we use is preeclampsia with or without severe features. We have said that for chronic hypertension, some of the assay can be the liver enzyme, the coagulation profiling, the serum electrolyte, blood urea, and creatinine. These are all the things that can be measured. Urinalysis, remember that significant proteinuria measurement we said earlier. And uric acid should be acid. But it is important to note that serum uric acid is not a diagnostic criterion for preeclampsia. We said that. And elevated gestational corrected uric acid serum levels are associated with worse maternal and fetal outcomes. This is contrary to what we said about the massive proteinuria, which we said has a worsening fetal outcome when it's massive. Then elevated uric acid needs detailed assessment of fetal growth. It's important to do that. But however, we must know that uric acid should not be used to determine the timing of delivery. This is very, very important. That uric acid is elevated does not mean that that is an indication to deliver the patient. Let's look at complications of hypertension disorders of pregnancy. These are renal impairment, pulmonary edema, HELP syndrome, eclampsia, cerebral edema, and there are so many of them. But what is important is that when you look at each of the each of the systems, hematological has its own complications, which can be up to the disseminated intracoagular coagulopathy, for hepatic and hepatic dysfunction, for renal, up to glomerular endotheliosis. The neurological is eclampsia, which nobody wants the patient to have, and of course the acute respiratory distress syndrome or pulmonary edema, which can be life-threatening if not recognized. This is important to know because if one does not know that there are other disease entities that can mimic all these complications of preeclampsia, it's imperative that the clinician might be thinking that the patient might even have gastritis, especially when they have maybe epigastric pain or gastric ulcers. But because one is thinking that this particular pregnant woman might have severe preeclampsia or might have eclampsia with severe features, so we know that this is not just gastritis, but it's actually a severe feature of a woman with preeclampsia. There are other differential diagnoses like Cushing's disease or thyrotoxicosis. This individual can also have elevated blood pressure, but high dose of physician should be able to note that one is dealing with eclampsia, preeclampsia. Pneumonia is also one of them, pulmonary embolus. So one must also look out for the differential and do appropriate investigation to be able to rule out this differential diagnosis. The involvement of the ophthalmologist should not be overemphasized, especially when there is involvement of the eyes. So patient can also have uveal melanoma. One must be able to note that this is not just uveal melanoma, but might be a derangement coming from preeclampsia with severe features. Let's look at eclampsia as we wrap up this lecture. Eclampsia means lightning. Very importantly, and we must know that eclampsia may actually present with no previously documented hypertension or symptoms. In fact, at this point, it can serve as a cause of confusion if the clinician does not have a high index of suspicion. The woman will usually be found to be hypertensive after admission with seizures. So this makes it easier. There is hypertension, there is seizures. The pregnant woman definitely we may be dealing with eclampsia. At the present time, all guidelines in use require hypertension in order to diagnose preeclampsia. So the most feared complication of preeclampsia are cerebral edema. Most of the time when there's cerebral edema, patients tend to convulse, and of course there's eclampsia diagnosis. But in terms of definition of eclampsia, we say the generalized tonic-clonic seizures in a pregnant or recently delivered woman with no other attributable cause. It's important to know that some metabolic factors, some neurological factors can actually cause seizures, but once you're able to rule out all this before you can say emphatically that this patient has eclampsia. It complicates up to 1 to 2% of severe preeclampsia, and search for an underlying cause should never delay initiation of treatment for eclampsia, because eclampsia can actually kill the woman, and it's important to deal with it as a situation that requires immediate attention. For all generalized seizures in pregnancy after 20 weeks should be managed as eclampsia. Let me say that again. All generalized seizures in pregnancy after 20 weeks should be managed as eclampsia unless a head trauma or epilepsy is diagnosed. So it is important to start off with management of eclampsia. You won't lose anything. But however, when it's obvious the patient has epilepsy, or a non-epileptic patient, or patient has head trauma, that may be, the management might be differ. And of course, that will require a multidisciplinary approach for the appropriate discipline that is involved. The most common preceding symptoms are severe headache, visual disturbances, and nausea. Remember, we said that some of these things, some of these symptoms can actually be seen in patients with preeclampsia with severe features. So once they start with visual disturbances, nausea, before one, that is why it is classified as severe, because those severity means that this patient can actually transcend from these severe features and definitely will now come up to have eclampsia. Up to 79% of cases will have these preceding symptoms. In other neurological disorders, we call them like aura, but in pre-eclampsia, we prefer to be a little bit economic with words. Cerebral damage is caused by a failure of autoregulation related to endothelial damage worsened by acute or large changes in blood pressure. So most of the time, because one of the theories of pre-eclampsia talk about the issue of vasogenic factors, release of toxins, oxygen radicals, damage of endothelia. So when there is damage, the same thing is because it's widespread. That can also occur in the vessels in the brain, and when they damage, water can leak into the interstitium, and that can lead to edema. And of course, when there is cerebral edema, of course, there will be enlargement of because the skull is non-yielding. That can lead to neurologic changes, and that can lead to seizures. Common findings in eclampsia is the posterior reversible leukoencephalopathy syndrome, PRES. This is very, very important, and once this is seen, it is almost eclampsia until proven otherwise. The PRES is a vasogenic edema of the posterior cerebral circulation. This PRES can also be seen in hypertensive encephalopathy. So, but there is something that is clear that one must note, that hypertension associated with eclampsia and PRES is often less severe than in non-pregnant hypertensive encephalopathy. So one must note that whether the patient is pregnant or not pregnant is very, very important in management of this outcome. Now, risk factors for eclampsia. We said one of them is nulliparity. Nulliparous women are at risk. These are documented. Previous eclampsia, pre-eclampsia, family history of pre-eclampsia, teenage pregnancy, primary gravidity, older advanced age, more than 35 years, or people with poor outcome of previous pregnancies. If a woman had delivered a baby with intrauterine growth restricted baby, or woman has placenta abortion, sorry about such women can have eclampsia in their subsequent pregnancies. The principle of management remains prompt diagnosis. It's important to establish what is happening to this woman. Then attempt must be made to abort the seizures. The recommended abortifacient for seizures remains magnesium sulfate, which is used worldwide. The stabilization and delivery to stabilize the blood pressure and deliver this woman through the most expedient route is very important. We use the word expedient because the safest route, and this delivery has to be, you have to consider so many parameters before this delivery is initiated. Remember, we said that coagulopathy is an absolute indication for cesarean section. Such coagulopathy must be corrected before that is, and again, cesarean section is not a must for a patient that has eclampsia. So for investigation, what are investigations that can be done for a patient with eclampsia? Computed tomography, CT scan, or magnetic resonance imaging can be done. Remember that there are other differentials. You can have a tumor in the brain, such can be detected. Consider lumbar puncture if clinical evidence is pointing toward meningitis. This is very, very important so that one can tilt toward the management, and the patient should have meningitis treatment. Urinalysis, as simple as it is key, must be done for the presence of proteinuria, for the presence of also glucose. Remember that patients with HONC, the diabetic complication can also have seizures. The uric acid must be assessed. The full blood count, remember to look at the peripheral smear and look out for blood cells and schistocytes. Liver function test is important. Total bilirubin greater than 1.2 milligrams per DL, or the liver function of greater than 772 international units, or LDH more than 600. These are all classic features that are in keeping with HELLP syndrome. And coagulation profile, remember we said international normalized ratio, prothrombin time, all this should be assessed. Then same electrolyte, blood urea, and creatinine should also be assessed. For the specific treatment, we said abort seizure, we said with the worldwide, what is advocated is magnesium sulfate with different protocols of use. Both in the one that is adopted by the Federal Ministry of Health is the pre-shot regimen for obvious reasons. There are other protocols, CBI, and the Sokoto regimen, ultra short and short. These are all in the view to abort the seizures. Airway support is very important. Most patients that is convulsing, the airway may not be patent, so it's important to ensure that the airway is patent by using the oropharyngeal airway as much as possible. If the tongue is falling out, remember to remove it or bring it out so that it will not fall back. Adequate oxygenation. Patient will need oxygen as when necessary, especially humidified ones. Blood pressure control is key. Remember to give the magnesium sulfate procedure because magnesium sulfate in itself has some anti-blood pressure regimen. So it's important to give the magnesium sulfate before giving the blood pressure and watch for some time. Sometimes by giving the magnesium sulfate, you might reduce the blood pressure to an extent, while before you now give the antihypertensives. Most of the time in eclampsia, it's important to give the parenteral antihypertensives with the antibiotic of choice is the labetalol. That can be used and be repeated use based on the current protocol. Nurse the patient in lateral position so that if the patient has some secretion that can come out and suction PRN as necessary. Stabilize, but before it's important to giving the magnesium sulfate. One, because if the patient is convulsing, it's important to give the intramuscular doses, which that is the regimen that is being used before securing, because the IV line in the patient that is struggling, that can cause some damage. So secure IV access after the seizures, critical fluid management. It's important to note that fluid management in eclampsia, pre-eclampsia is very important because they have contracted ECF so that in the sense that if you give them too many fluids, instead of entering into the vasculature, it will enter into the institution and that can worsen whatever effect that is being experienced. Therefore, it's important to keep the fluid management at least 80 to 100 ml per hour based on the fluid regimen that is being given. A dose of steroids can be given if the fetus is less than 34 weeks, so that to ensure that the lung is matured, and also to prevent the necrotizing enterocolitis and the intraventricular hemorrhage that can follow preterms. It's important at this point to place the patient on Neopa oris until the patient is able to avoid aspiration pneumonitis. Deliver this patient because it's important. We said that eclampsia is treated by delivery after stabilization, and we said it's the most expedient route. The mode of delivery is based on obstetric indication. If the patient is coming to you and is already fully dilated, and you have the protocol means that of forceps, you can go ahead and deliver the patient using the instrumental delivery, or vaginal delivery is preferred considering the mother, but that will follow all the necessary protocols of vaginal delivery, ensuring that there are no contraindications. Ensure adequate analgesia in labor, very important, and consider to have induction of labor with reassuring fetal status. Remember that the protocols on induction must be met, but should not be allowed to be prolonged unnecessarily. Remember that eclampsia, pre-eclampsia is a continuous disease and can worsen with time. Consider cesarean section in unfavorable cervix and when gestational age is less than 30 weeks. And just remember that also, as you are considering all this, multidisciplinary approach is important. The anesthetists must be involved in all this management, and the neonatologist, so they ensure that there is neonatal backup for the fetuses that are coming out in very tender gestational ages. Where cesarean section is considered, rular coagulopathy, we said that time without number, and correct where present. Also, where there is coagulopathy, this is not a patient that you consider to give regional analgesia, because they can actually bleed into the CSF, and of course, that can be complicated, that can be disastrous. Consider in disoriented maternal status, control blood pressure, send consult, like we said, and the theater personnel. Remember to discharge the patient when deemed necessary, and to see 1 to 2 weeks after delivery. Check for blood pressure control once more, and refer to the medical personnel if hypertension persists 8 weeks after delivery or their development on neurological changes. Please, the patient for a eclamptic patient must be noted. This must be documented very clearly in the case note, so that any physician seeing this patient subsequently will know that is a patient that is at risk of subsequent eclampsia. And remember what we said, that this patient upon discharge can be told that she is actually at risk of developing another eclampsia. If she merits to be talked about the issue of contraception, one can tell her that she's at least the liberty of having contraceptives within, so that if she can actually even close a pregnancy or close delivery, that will be fine. And of such a patient, so there will be the occurrence of the risk is minimal, as the patient is not going to deliver. But if the patient is going to deliver once more, please let the patient know that the risk is still there. Some of the highlights of the 2019 Task of Working Group for Hypertension during pregnancy recommended that you must take history to assess risk. Vitamin C and E are not recommended to prevent preeclampsia. They recommended that daily low-dose aspirin for prevention of preeclampsia in higher-risk preeclampsia and premature birth is recommended. Studies have shown that 150 milligrams of aspirin given at night in high-risk women for preterm preeclampsia on the basis of screening with maternal factors, Doppler studies, maternal placenta growth factors, and reduced incidence of preterm preeclampsia can reduce it from 4.3% to up to 1.6% in the aspirin group. The other trial also said that the calcium at dose of 1 gram per day has been shown to reduce the likelihood of preeclampsia in women with low calcium intake. The low calcium intake was defined as intake of calcium less than 600 milligrams per day or the use of calcium 1 to 2 to 2.5 grams per day in women at increased risk. Aerobic exercises for up to 50 minutes. Before, we used to talk about 30 minutes, 3 times per day in one randomized controlled trial that involves 765 women has been associated with reduced gestational hypertension and preeclampsia, as well as less weight gain and the delivery of macrosomic infants. And other trials have also shown that severe hypertension was associated with significant greater likelihood for low birth weight, prematurity, death, and mobility requiring neonatal unit care in neonates, while thrombocytopenia, abnormal liver enzyme with symptom and longer hospital stay in the mother. The recommendation also talked about the prenatal corticosteroid to be given between 24 weeks up to 34 weeks, and to also consider these corticosteroids up to 38 weeks in cases of elective delivery by cesarean section. Multiple steroid doses are actually not recommended, and the magnesium sulfate can be given for other reasons, not just for seizure, to abort seizures. It can be given for neuroprotection, and this must be administered prior to fetuses that are less than 32 weeks. To ensure euvolemia, we have said before that not using more than 80 to 100 ml per hour. I've said it before, to avoid of fluid, to avoid the risk of pulmonary edema. Insensitive losses should be replaced at 30 ml per hour along with associated urinary losses. Let us summarize this lecture by saying that it is important to treat the emergent hypertensive conditions rather than to wait 4 hours to confirm diagnosis. That's previous recommendation. Use of non-steroidal anti-inflammatory agents as first-line treatment of pain postpartum over opioids because they do not affect the values of arterial blood pressure. Quantitative examination of protein in urine for 24 hours or protein creatinine ratio are better. But if these tests are not available, protein should be diagnosed as 2 pluses per test strip instead of 1 plus. Classify patients into groups during antenatal is very, very important. And the proteinuria is no longer a must for diagnosis of preeclampsia. Stabilize and deliver eclamptics through the most expedient routes. Avoid regional analgesia and anesthesia when coagulopathy is diagnosed. Follow up these patients and refer by 8 weeks postpartum if hypertension persists. Thank you for listening.